Welcome back, everyone, both here and joining us online. This next session, Sustainability in Aging Society, Improving Quality of Life for People with Disabilities, addresses the critical challenges individuals face in ensuring accessibility, healthcare, and economic stability. We're privileged to have global experts joining us online and in person to discuss how disability-inclusive policies can be integrated to broader development agendas, ensuring sustainability and equity for all. Please join me in welcoming the session moderator, Professor Eun-Ah Han, a professor in the School of Pharmacy at Yonsei University, who will introduce the speakers for this session.
Good morning, everyone. Thank you for the introduction. As was introduced, I'm Eun-Ah Han, professor at the College of Pharmacy at Yonsei University. The previous session, the special conversation, was very interesting, but in this session, we're going to discuss something that has a wide impact on many aspects of sustainability, which is health, and we are going to focus on improving quality of life for people with disabilities. And so we will hear from Korean experts, and then we will invite Professor Jennifer Smith-Mary to hear about what's happening overseas. Let me briefly introduce our three panel members. The first speaker is President Kang Yoon-gu of the National Rehabilitation Center. He's sitting to my right. So he's serving as president of the National Rehabilitation Center, but previously he was a professor of the College of Medicine, specialized in rehabilitation at Korea University. And for almost 30 years, he focused on patient outcome, on quality of life, and he has been very productive as a researcher. The second presenter is sitting next to my left, Professor Chun Bo-young, assistant professor at the Department of Health and Medical Information at Myungji College. And so she has extensive knowledge and research expertise on health and rehabilitation. She used to work at the National Rehabilitation Center before moving to Myungji College. Now we have with us Professor Jennifer online. Professor Jennifer Smith-Mary. She is a professor at the Department of Health and Social Policy at the University of Sydney and Australian Laureate Fellow. And she's also leading the Disability and Policy Research Center at the University of Sydney. Last year, we invited her as a speaker. So she's a world-renowned scholar, and she has extensive experience in social policy research, especially for mental health and disability. So we look forward to her presentation, as well as the other two members. This is a rare opportunity. I'm very happy. Now, I'd like to conclude my remark as a moderator, but let me invite Dr. Kang.
So it is a great honor for me to be part of this important forum. And with that, I'd like to start my presentation. So I want to talk about rehabilitation. So what rehabilitation is, and I try to connect rehabilitation with SDG. So actually, at the end of last year, I was invited as a speaker for this session, and I've been thinking about this topic ever since. My presentation title is Rehabilitation is Smart. But smart means aren't bridging the medicine and the society. So that's what the smart means here. So this is the contents of my presentation. PQR, when you get various waves from your heart, and those waves are called PQR. So I kind of used that acronym here, and this is our logo. National Rehabilitation Center. This is the only institution in Korea with 40 years of history dedicated to rehabilitating people with a disability. So our mission is to shape a world for healthy people with disability. And also we work with the WHO as well. They're collaborating Center for Rehabilitation. And this is our organization chart. So in the middle, our biggest organization, Rehabilitation Hospital Division. On the left, we have Rehabilitation Business Division. And on the right, red, we have a Rehabilitation Research Center. So we are under the Ministry of Welfare and Health. And this is some statistics about the number of registered people with a disability. So here I want to talk about the connection between people with a disability, their rehabilitation, and SDGs. In Korea, as of 2023, there are about 2.65 million people living with a disability in Korea. About 5% of the Korean population are living with disability. And out of them, because now we are also talking about the elderly population, so people aged at and above 65, they take up about 5.1% of the total population with disability. So old age comes with disability, so to speak. And as you can see here as well, this is a more detailed breakdown of the age group. As you get older, bigger portion of people with a disability. So as you get older, you become more likely to develop disability. And the same story, but per types of disability here. So for example, auditory impairment, visual impairment. And there are new registered people with a disability. So people who are newly registered as a person with a disability. Again, these are new registries. 56.3% comes from the elderly population. And if you look at the mortality rate or early mortality rate, it's we look at the death rate per 100,000 people, and here the death rate from people with a disability is 5.3 times higher than people without disability. So even within the same age group, if you have disability, you're 5 times more likely to die early compared to your age peers. And this is a mortality rate during the youth. The graph is kind of reversed here, so you can see. So it's not that young children die a lot, but relatively speaking, youth with a disability, they still die more compared to their peers without disability. And early death rate, we can see the number quite high among certain types of disabilities, for example, brain disability, kidney disability, respiratory disability. Now I want to talk about health and SDG. Because of the limited size, I couldn't input a lot of information inside the circle, but you have a PQRSD. This is not the original SDG drawing. I actually kind of made some adjustment to the original logo. So out of the original goals, goal number 3 is about health, and number 3 is about good health and well-being. So good health and well-being, what is their relationship? I want to go back to this later on. So I was looking for some materials to include in my presentation, and I happened upon this drawing. And again, the original drawing is kind of different. I made my own modification to the original drawing. Goal number 1 is about ending poverty. But I wanted to see that there are some relationships between goals. So I added those arrows. So if you follow all those arrows, all lead to goal number 3. So that goes to show you that good health and well-being are really important, or we could say that good health and well-being are the ultimate goal of the SDGs. So we need to take a look at the definition of a good health and well-being. In Korea, there are 9 goals under the goal number 3. So you can see that goal number 3-8, overcoming a declining fertility rate and responding to the aging population. That is a part of our topic today. And WHO was established in 1948. So this is the definition of health according to the WHO. Health is a state of a complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So here, physical, mental, and well-being are included in the concept of health. But still, I find that this is not specific enough. So WHO also issues various statistics, and out of these statistics, ICD, International Classification of Diseases and Related Health Problems, and this is the oldest statistics. So this is kind of a disease classification system. So if you look at here, we see health and health problems, and the direct cause for health problems is disease according to this classification. But for me, disease is more like a cause for death. It's not necessarily a direct cause for health problems. And also, due to that kind of thinking, a new classification came out. But there is a complex history in between. So I want to draw your attention to this 2001 classification, International Classification of Functioning, Disability, and Health. So here, finally, there is a distinction between functioning and health. But I believe that functioning and disability takes a second priority. Health should be the top priority. So health classification should come first, and then underneath, functioning and disability should follow. That is my thinking. But I guess because classification is so complex, this is what they came down to. And next concept is operationalization. So health is like colorless and transparent light. So once this light called health goes through a prism, then it can produce a rainbow colors. So a spectrum of colors. So I think this spectrum of colors is the real face of health, real status of health. But we cannot desegregate health. I think that is why functioning, the concept of a functioning came in to talk about various aspects of health. And there is a health spectrum, and within this color spectrum, there are pieces, over 1,400 pieces. And those pieces are categorized under body functions and body structures, or activities and participations, or environmental factors. So International Classification of Functioning and Disability and Health, that classification covers all these concepts. So that is the definition of health. And with this concept, now physical, mental, and social well-being are color-coded here. So now social health is an aspect of health. For example, is this person healthy enough to be socially active? and is this person able to take care of themselves? For example, having meals throughout the day. Can this person do that on their own? Is this person healthy enough to attend the school? So these physical, mental, and social well-being, this is the psychosocial model of health. So health is functioning, and it is about leading your life. Then let's see what kind of relationship the concept of health has to disability. So again, classification about disability, but here functioning is, so there is a functioning on the left-hand side, and the opposite concept to functioning is disability. And also the opposite concept to health is also disability. So disability is really kind of involved in many aspects of health. Mental health can be classified as disability as well. And now you also add environmental aspect as well. So if there is something wrong in the environment, then you have a disability. So the scope of functioning or the scope of disability nowadays is much more broader. And health, this simple word, encompasses all these aspects. So this is the logo. Again, we see functioning and disability as two polar opposite concepts. And also, every functioning issues have some kind of disability issues. If you throw me specific questions, I can give you an answer. For example, I also have a disability. For example, I'm wearing glasses. So that's my disability and my age. So I'm older than 65, so my old age is also part of a disability category. So we often talk about aging into disability. So as you get older, you get an older person, and also you develop a disability. So, and also there is a concept of aging with disability. So you age with disability. So as you age, you develop disability, and as you age further, you age with a disability. So age with or into disability, now this is an important concept. It's a very comprehensive concept. So we can think about this kind of picture. And disability, aging, sometimes we combine these concepts together into chronic conditions. But the end of the chronic conditions is frailty. And we want to respond to frailty, and there are three approaches to deal with it. It could be a tool for rehabilitation, and it could be also a preventive tool. So specifically, physical activities, nutritional state, and the social engagement. So these are three major approach to respond to frailty. Again, health is about functioning, and functioning problem is a disability problem. So rehabilitation is about dealing with this, and rehabilitation is really about rebuilding a person's life. So if you look at the word rehabilitate itself, you have re and habit, and we also live together. Human beings live together, and every day your daily life is part of your habilitation practice and habilitation journey. Sometimes we use the concept of intervention and medicine and restore complete physical and mental and social well-being. This is an important definition of rehabilitation. So basically, rehabilitation can be defined as restoring a person's complete holistic health. And the goal of rehabilitation is ultimately to improve the quality of life. And another goal is to have interdependence beyond independence. Oftentimes we say rehabilitation is about gaining back your independence, but I think independence is not enough. We need to go for interdependence beyond independence. If you look at the SDG goals, goal number 17 is about interdependence. To me, SDG goal 17 seems to be very in great harmony with the concept of interdependence. So as we pursue rehabilitation, the first step, the first small step in rehabilitation is aging with age. So what is AGE here? AGE, active, gentle exercise.
내용이 뭘까 하면 한숨.
And what is in this? It means sighing, strolling, stretching. So I intentionally chose words starting with S because these are actually really great small steps towards rehabilitation. So rehabilitation is also about moving forward together with the disability. And every moment you live with disability is also a moment towards rehabilitation. And we can think of a biopsychosocial model for rehabilitation. And to conclude my presentation, we need to bridge medicine and society. When we bridge medicine and society, then health, welfare, well-being, these two can be connected. So rehabilitation is the connecting bridge between health and welfare. That is my concluding message to you. So when I say rehabilitation is smart, rehabilitation is smart, but it is a really smart, smartness itself. So it's smart to pursue rehabilitation. So social and medicine. So there is an art in between social and medicinal here. So I believe a good rehabilitation should be smart. Thank you very much.
Thank you very much, President Kang, for your presentation. The rate of aging is very rapid, and soon we'll have 50% of the total population aged 65 and older. So aging comes with disability, and we need to think about helping people to maintain their daily lives as they age when they experience disability. Now I'd like to invite Professor Chun. Hello, everyone. I am Chun Bo-yeon at the Myeongji College. The previous presenter did a wonderful job, and his presentation made me think once again about the definition of rehabilitation and this spectrum of colors, the rainbow colors. I'm going to talk about the presentation titled Bridging the Digital Divide, Aging, Disability, and Health Equity. There are elderly with disabilities, and there are social determinants of health and digital determinants of health, and we need to think about them both at the same time. So I'd like to share with you my research findings. Today, I would like to focus on bridging this digital divide rather than focusing so much on sustainability. As was mentioned previously, we are experiencing aging population, and as you get older, your existing disabilities may get worse, or you may acquire new disabilities. Now, in this case, you can see people with disabilities, as they get older, their disability conditions may worsen, and there's this issue of aging. And with frailty and aging, people may acquire disabilities nearly. So there are two types of people with disabilities, aging with disability and disability with aging. In Korea, this notion is very limited, but when you look at other countries, you will find that there's a higher percentage of elderly people with disability. There are three key characteristics. There's health issue, of course. Elderly with disabilities have shorter life expectancy than others without disabilities by 16 years, and they would have to live longer in poor health conditions. So there are two main conditions that we need to recognize. And socially, because these people have received less opportunity or because of lack of employment, when they get older, older than 65, they would not really have much financial income. So the percentage of elderly with disabilities is higher. The poverty rate is serious. In addition, this is the biggest issue experienced by elderly with disabilities. When you think about long-term care, there is a gray area. The Disability Activity Support Program will be shifted to the long-term care program. So people with disabilities, when they get older than 65, they will have to switch to a different set of systems and services. So they will not be able to receive care for longer hours, and the kinds of services that they receive after the age of 5 are rather limited. So there was an amendment to the Disability Activity Support Act in 2021. Despite these amendments, the reality is that elderly with disabilities do not receive sufficient care, and their services remain fragmented. Now, as I mentioned before, people with disabilities, their expected life expectancy is shorter than those without disabilities, and there are several determinants of health. And the first type of determinants of health is social determinants. SDH or SDOH are social determinants of health, SDOH, and these factors influence health outcomes. But in more recent years, there's a lot of talk about utilizing this notion of digital determinants of health, DDOH, which do have impact on health outcomes. For instance, there are people who are able to access digital devices and use such devices, or there may be digital information gap or other divides in terms of digital availability. So these types of determinants need to be considered as well. Well, we need to consider digital determinants of health because of the rise of digital health. Digital health is a rather comprehensive concept. It includes a wide range of health-related domains, and more people benefit from digital health. And so this new type of service, digital health, has become an important part of our health management. Then who will benefit more from digital health? Even within people with disabilities, who will benefit from digital health and who will not benefit from digital health? And this diagram shows that if you're young and if you have high digital literacy and if you have mild disabilities, you will be able to benefit from digital health so that you can reduce the health gap between those with disability and those who without. And indeed, young people with disabilities are able to utilize digital devices, many different kinds of digital devices, to improve their quality of life. However, there's a different story for older people. Older people with severe disabilities that have low digital literacy struggle to utilize digital health. And when there's increasing use of digital health, there will be increasing gap between those with disabilities and low digital literacy and those without disability and with digital literacy. So this may end up creating digital divide that is unintentional. Now, this type of digital divide can cause two types of health inequalities. First of all, for people with visual impairment or hearing impairment, they lack access to digital devices because of their disabilities. And when such lack of access continues to accumulate, this will lead to very different health outcomes. For example, there are diabetic patients, and some people are able to use digital smart devices to manage their blood sugar levels. But then there are others who cannot really use smart health devices in managing their diabetic conditions. And after several years, such impact will continue to build up, and they will lead to very different health outcomes. So we need to think about digital health equity, and in doing so, we need to think about different aspects. So first of all, we need to think about individual level consideration. Different individuals have different levels of digital literacy and digital self-efficacy and technology access. And another level is interpersonal level between patients, technology, and clinicians. And the third level is community level, whether such digital health is available in the community. And finally, societal level, which has to do with government policies and technology standards for digital health. So this is more of a macro level consideration. So at all these 4 different levels, we need to consider digital health equity and divide. Now, in our society, what has been done to promote digital health for older adults? Let me give you some examples. The first case is using AI, IoT for older people. Since 2020, so we are in the 5th year, and this project has been very successful. For instance, the walking and other health or physical activities have increased thanks to the digital device. However, this type of project will be beneficial for healthier seniors, but for those who have severe disability conditions won't really be able to benefit from this, because in order to use this, you need to walk to the residential center. You also need to download an app and be able to use the app. So this type of program will not be inclusive enough to include people, older people with severe disabilities. So you need to think about your programs, whether they are inclusive enough. And secondly, there are some social changes with respect to people with disabilities. One instance is in 2024, there was an amendment to the Pharmaceutical Affairs Act. So it mandates the display of drug safety information in Braille and audio sign language video codes so that everyone can get access to health risk information from medication. So this is more of a public sector policy. And in the private sector, there was an increased utilization of telemedicine during COVID-19 pandemic. However, such changes are rather limited at this point, and we're not confident as to whether these changes or these initiatives have contributed to better health for all citizens. So there's a lot more we need to do going forward in terms of how to reduce the digital divide for elderly with disabilities and improve their quality of life. And we need more research. Also, there is a lot of diversity within people with disabilities, and we need to consider that. And as for call for action, individuals, healthcare providers, digital technology providers, and the government and government agencies have a role to play. And so I've laid out what they can do. In the past, digital technology providers were not considered in terms of health care and health policy formulation. But now we know that digital technology is an integral part of our life. So we should not exclude that, but rather we need to promote digital inclusion and universal design in early stages of technology development so that digital technology and solutions can be utilized by all people, including elderly with disabilities. And then such digital technology can contribute to better health. Now, with that, I'd like to conclude my presentation. Thank you. Thank you very much for your wonderful presentations, Professor Chun. A lot of people are interested in digital literacy. And when we talk about digital literacy, we also think about digital divide and digital equity. And there are growing social concerns over increasing digital divides. In particular, in aging society, there are people with disability, and digital devices are supposed to help you in your day-to-day activities. But there are situations where digital devices rather exclude some people from such benefits. Now, I'd like to invite the third presenter, Professor Jennifer Smith-Mary from the University of Sydney. She's joining us online from Sydney. And so she's joining us real time. And the first two presenters talked about cases in Korea, but now Professor Smith-Mary will discuss how Sydney and Australia is promoting quality of life for people with disabilities. Please go ahead.
Thank you very much. It's a great honor to be joining you. I'm sad to be joining you from afar. I really enjoyed my time visiting last year, and particularly visiting the National Rehabilitation Centre and my time there. So I hope to come to Korea again to join you. But today I'm going to talk about how we can take these ideas about disability inclusion and create policies that are going to provide us with the most powerful ways of including people in society. So I've chosen 3 key areas that I think we need policy action in. So these 3 areas come from the work that I've done throughout Australia, but also throughout the Southeast Asian region and from when I was working in Scotland. And so these are 3 areas that I think work across both countries that have low resource settings, but also countries where they're high resource settings. And that's important because in terms of the Sustainable Development Goals, we need them to be operationalized within all regions, not just high resource settings. So I've chosen those 3 areas for that reason. My own research, I'm a policy researcher by background, but I've been trying to create policy or think about how we can create policy that really understands the experiences of people with disability themselves. Because often our policies might be created with too much focus on drivers that are not linked to the actual experiences of people with disability. So I try to connect people with disability on the ground and the policy making environment and the economic and social imperatives that have to operate there to the real lives of people with disability. So these are the 3 areas that I've chosen to focus on: early intervention, employment, and community as well as individual approaches to disability inclusion. But first I wanted to, I'm going to talk about early intervention, but first I wanted to talk to you very briefly about Australia's National Disability Insurance Scheme. I'm saying that because I'm using Australian examples mainly in this presentation, and it's really important to understand the National Disability Insurance Scheme, also called the NDIS, in Australia, because this is a major national policy that is provided as a universal insurance scheme for people with disability in order to ensure social inclusion. So it provides significant supports to help people with disability be included in their own communities. It does that through providing an individual budget for people with serious functional needs, which then they can use in order to pay for supports in a disability support market. So if I was a person with disability, I would be able to receive a budget that matched my support needs, that then I could go and employ say, speech pathologists or occupational therapists, or perhaps cleaners, or to buy particular types of technology that's going to support my inclusion in the community. This is available from birth to age 65, though people can stay on the scheme after 65. And the aim in being a universal insurance scheme is this idea that Professor Kang was talking about, which is that people can develop disability at any time in their life. Previously, we had insurance schemes that were only for people, say, who had developed disability through a motor vehicle accident. But your support around your disability shouldn't be dependent on how you got the disability in the first place. So this was brought in, and it's a major national policy in Australia that costs upwards of 35 billion Australian dollars per year. And it covers around 610,000 people. Now, that's compared to about 4.4 million people with disability in Australia, including 2.4 million under 65. That's an estimation because we don't have a registration scheme for people with disability in Australia. The primary diagnoses for people on the scheme are autism, intellectual disability, and psychosocial disability. Now, that's important here because we include severe mental illness as a type of disability in Australia that is covered under our disability supports. And it's meant to be lifelong support for permanent disability. So that's just a little bit about the policy context in Australia, and I can answer questions later about the NDIS, but I think it's important to understand that as I talk through the other parts. So back to early intervention. The idea with early intervention, and this is one of the reasons the NDIS starts at birth, and it's not just a scheme for people later in life, is that if we intervene early, then it creates lifelong benefit. It creates improved developmental outcomes for children as they age, which then allows them to achieve better sort of cognitive, social, and emotional development, and to be included in schools. So it enhanced learning and educational opportunities, and that reduces the need for special education, but it also increases the ability for people with disability to enter the workforce and therefore to be independent in their lives and not reliant then on government welfare schemes or their families in order to get support. It also leads to increased independence and self-sufficiency. So early support can lead to better long-term outcomes in terms of daily living skills. If you develop those daily living skills as you mature, it's much easier then to develop those daily living skills later in life. And it also, it's improved cost savings for families and society. So early intervention can lead to cost savings down the track. So it's worthwhile the government sort of top-loading disability supports early in life in order to provide, to mean that there's less expenditure later in life. And it also increases society as a whole, because the more that you include people earlier, the more that other people in society can see that inclusion alongside them as they age and understand that disability inclusion then is normal. But we also need to think about bridging the gap between specialised rehabilitation services and mainstream supports. It's absolutely essential that there are specialised rehabilitation supports for people with disability. But what we found in Australia is that some early intervention under the NDIS does not actually build capacity, but builds dependency. So one of the problems with having an open disability market where people can buy supports is that the market provider then becomes dependent on the person with disability for their ongoing economic viability. That type of environment builds dependency. It doesn't it doesn't enable, it doesn't encourage the provider to enable independency, because they might feel that they need to continue a relationship in order to have that financial connection. They've got a vested interest in providing ongoing support. Early intervention outside of mainstream services can also perpetuate the need for expensive specialist supports when people can actually move into more generic supports in the community through the education system or through general health system. And through having more people with disability in mainstream services, it develops the skills of those services in supporting people with disability. So policy frameworks that support this early intervention goal include pricing that supports participation. So one of the ways that you deal with private providers wanting to hang on to their clients is that you price things so that there's an incentive to get people to move off services. So you want to then, as a government, to say, we're going to fund you, but only if people are setting and meeting their own individual goals in terms of functional outcomes. So they're not just staying at a static state of functional impairment. You want people to improve in terms of their functional inclusion in society. We need to measure outcomes. Often we don't measure the outcomes of the supports that we put in place. We also need cross-government working. Sometimes disability is put by itself in government, but it needs to be really included in the way that health and education and other systems are developed. And we need support for families in order to enable children to take part in early intervention. And there's a bit about community education there as well. The other really important way of including people in society is through employment. The benefits of disability employment include financial independence, so a steady income, as I was talking about before, to decrease reliance on social assistance programs. Often those social assistance programs, where they exist, only enable people to live in poverty or just above the poverty line. So employment addresses dependency also on those systems of welfare, but also on families. People gain an innate sense of purpose and achievement when they have a job, and it boosts self-esteem and overall mental well-being, which is really important because we know that mental well-being is reduced for people with disability. Workplaces that offer opportunities for social interaction and build relationships, that addresses the loneliness that we find often in people with disability and older people with disability. So it creates a social inclusion through just interacting in terms of work. But employment also allows individuals to develop new skills and gain experience, which then further enhances personal growth and career prospects. In Australia, we have low rates of people with disability in employment. So only 56% are employed at all, compared with 82% of people without disability. Only 33% of people with disability are employed full-time, and only 64% of those with moderate or mild limitations were in employment. Now that's important because you would expect those levels to be much higher and much more closer to people without disability. Only 37% of those people with profound or severe limitations are in employment, and that's any employment, so it could be 1 hour a week. The reasons for this are about, I think, poor understanding of disability on the part of prospective employers, limited government supports for subsidizing the financial cost of inclusion. So a lot of employers won't employ people with disability because they can't afford the outlay involved, and a lack of motivation. So either an extrinsic motivation, like they're being forced to include people, or intrinsic, so people don't feel the need to include people with disability. The benefits beyond the individual are that they address workforce gaps. We often in Australia, we have big workforce gaps in some areas where people with disability could really be involved, such as disability services themselves. So we could target our policy towards addressing those workforce gaps that we know that we have. Enhance company reputation. So inclusive and diverse companies are often, viewed more favorably by the customers and clients. Diverse perspectives. So people with disability, they bring a different understanding and unique perspective. So I'm an employer of many people with disability myself, and I find that the perspectives that people with disability bring to our research are really invaluable because they give unique perspectives into the way that we do our work, and it makes us more creative as a team. And then increased employee loyalty. We actually know that employees with disabilities often have high levels of dedication and loyalty, which is good for companies in terms of lower turnover and increased stability. Policy frameworks to support disability employment. So they are both supply side, so working to create people with disability that are able to enter into employment, and demand side, so employers being encouraged to employ people with disability. So I think some of the policy measures are around having higher standards of education for vocational success through mainstream schooling, rather than unnecessary segregation. Hard measures such as quotas, and they can be universal or sector-specific quotas. So in Australia, for example, the government is considering bringing in a quota for disability services that receive funding from the government. So in order to receive particular types of funding through the government, services would need to employ a certain number of people with disability. Then universal quotas such as taxation, penalties for companies that don't employ a certain number of people with disability. Then there's soft measures such as public education to counter stigma, because one of the reasons why employers don't employ people with disability is because of a stigma or discrimination against people with disability. Government support for disability-related accommodations in the workforce, so strategies that are going to help support someone, such as screen readers for blind people or accessible workplaces. Support for entrepreneurship, so programs to encourage people with disability themselves to be self-employed and develop their own businesses, and programs to develop leadership in people with disability. So we have disability employment right at the top of organisations, not just in the lower skilled parts of organisations. The final thing I want to talk about is the importance, and I think our last speaker was talking about this, of balancing individualised support with community-focused support. So one of the problems we have with the National Disability Insurance Scheme in Australia is that it's focused on the individual. So individuals get money for supports, but what we're missing is the community around that individual. Individualized approaches are really great because they promote independence and autonomy. They help them to develop skills themselves that are relevant to their own lives, and to have individual programs that are going to support them. They enhance quality of life through having care that is personalized rather than focused on, care that is just for a particular diagnosis or disability group rather than the individual. And that helps to cater for specific disabilities to create the right resources for every person. Community-based supports, on the other hand, really foster social interaction, and that's good for people with disability and people without disability. So it reduces isolation for people in the community more generally, but for people with disability specifically, building self-esteem and confidence in individuals. It promotes inclusion and acceptance in the community, so we have more tolerant societies. And it supports the individual in the context of their community, so the community can then support the individual's rehabilitation as well. So supports so the community is better educated in order to support the individual. Policy frameworks that really support this balance between individualized and community-focused inclusion focus on person-centered rather than diagnosis-centered approaches, inclusive community development practices to create supportive environments that embrace diversity, so anti-stigma, anti-discrimination programs, individualized funding that focuses on the individual but also supports community centers and communities that are able to provide more general services rather than just for the individual. Programs that target the carer, because carers are so integral to supporting people with disability, but they're often forgotten in individualized funding streams. And then trying to measure as a government social inclusion, social participation, and reductions in loneliness as a government outcome to indicate government policy success. So in summary, our community really thrives through diversity, and there are strong economic and social benefits to strategies to include people with disability that go beyond the sort of implicit value of equity. So there's really strong economic drivers for including people with disability in terms of reduced health and social care costs, increased employment of people with disability, increased social functioning in the community as general. So the governments need to take action through the evidence-based policy actions identified here, and there is really good academic evidence around the benefits of these programs. So I'm going to end there, and I'm again really thankful for being invited to speak today, and I hope that this inspires some discussion around more of the things that we can do at a government policy level in order to increase quality of life for people with disabilities.
Thank you very much, Jennifer, for your presentation. So it is important for people with disability to conduct their daily lives in the same manner as others without disability, and we need to put in place a system or government policy to ensure that. And we need an overarching design that can promote better quality of life for people with disability. We are running short on time, but we have a very special panel with distinguished scholars, and I believe that you have a lot of questions on your mind. As we get older, we will have some sort of disability, so this is not something that is not related to you, but it is relevant to all of us. And Professor Chun talked about digital health, and President Kang talked about rehabilitation and also preparation. And so in this regard, I'd like to open the floor for questions. If you have any questions, then please go ahead. Thank you for your wonderful presentations. Our society is experiencing an unprecedented rate of aging population. And I'm a medical doctor myself. But when it comes to medical treatment, there are many cases where patients are not completely treated but will have to live with chronic health conditions. So this is our reality. Now, As I said, there are many members of our society with disability, but the society as a whole seems to believe that it is a burden, and it is actually increasing costs and burden. So what kind of action do we need to take to address this so that we can engage people with disability more actively in our society, which can alleviate our burden or the sense of burden? So what do we need to know to be able to engage the people with disability in our society? Well, this may be addressed by each of the panel members. So first, President Kang.
Well, I don't have the right answer, but let me try. Because I also come from the medical background, for example, preventive medicine, rehabilitation medicine, and treatment medicine. But because I work mostly in the rehabilitation area, it always goes back to how can we prevent that? Rehabilitation issues always go back to the issue of prevention. So as I try to help my patients get rehabilitated, it is also about preventing the cause. So as we see people aging into disability or with disability, we can see spots where the problems occur. So that's something we need to all share and study on.
Whenever I conduct research on people with disability, I imagine a world where people with disability can live happily. And if we create such an environment, this will also be good for people without disability. For instance, elevators and also for digital devices, when they're easy to use for anyone. If we have good elevators and if we have these ramps, and ramps are not just good for wheelchairs, but also for strollers, moms with babies. They can they can have better accessibility. So such a design concept can be good for everyone. And if, for instance, fonts and designs are easy for people to read, then this will not only be good for people with some visual impairment or older people, they will also be good for younger people and others without disability. So we need to change our mindset in that regard.
I think that the most important thing we can do is try and include people with disability in every aspect of our lives, in education, in what we see on television, in the people that we see on the streets. I think inclusion of people with disability allows for a destigmatizing of people with disability so that people are less frightened of disability and that it's seen as a normal part of life. So many people in society have disability, but it's seen as something that happens to other people. I think the good thing about the National Disability Insurance Scheme in Australia is that it normalised disability. And when the government presented it, they said, this is a scheme for everyone because everyone has the potential to develop disability. So I think it's trying to change our national, the way that we see society and see people with disability in society, having more people in society, and the way that we talk about people with disability in our national media and in our national governments and schooling and all of those parts of mainstream society.
Thank you very much. On top of that, I'd like to offer my own thoughts. The word disability includes many different aspects. because disability includes people who are born with disability, people who acquired disability later in life, and there are different degree of severity in their disability conditions. So there's a lot of differences within this term disability. So we need to be able to cater to individual differences, but at the same time, we need to have more predictability as to the kinds of services and programs available for people with disability in different stages. So the key word is, okay, disability is not an isolated portion of our society that is separate from the rest of the society. There's stigma, there's some negative perception, and some people say that disability causes social burden, but we need to be able to overcome that, and I think that should be the starting point. It is 12 p.m., but I'd like to accept one more question from the floor. If not, we can conclude. Are there any questions? Okay, someone in the back. Can you say your name and your affiliation and to whom you're asking? I am Jung Yun-seo. I study religion, and I'm a student at Yonsei University. And I learn that aging and disability are sometimes considered to be elements of costs and burden, and that is what it is right now, unfortunately. Then, for people with disability and for the elderly, we need to create a world where they're more engaged. And when there's a higher level of engagement, this may lead to more economic benefits or social benefits. What would be the advantages we can expect by including them more? Well, I don't know who I should ask this question. I didn't really have any panel member in mind. So maybe. Well, so as you said, disability, people with disability and senior citizens, when they are more involved and engaged in our society, there may be certain benefits. So you are wondering what these benefits would be. And I believe we first need to be clear about the definition. So what society and what kind of involvement? Well, near here, there is a place called Mapo District, and in this Mapo District, there is a cafe where they serve tea and coffee and desserts, and they hire people with disability, and they hire older people. So you can see that they're working hard, they enjoy their work and working in this cafe. So this is an example, but that's actually for people with mild disabilities. But then there are people with severe disabilities. We can give them some digital device so that they can express their thoughts and they can offer their creative side. And so there are many different ways of engaging them and including them in our economy, in our society. So overall, I hope that there will be a lot of benefits. Thank you.
Professor Jennifer, do you have something to add based on your experience in Australia?
Yes, I think that the most important thing is having conversations with people with disability to understand what their needs are. I'm just picking up on that last comment. I have a staff member who cannot come to work. Everything has to be telecommute. They can't participate in anything face-to-face. They are one of the best workers that I have. But I wouldn't know that they had those abilities unless I was able to look beyond the immediate difficulties we might have with changing the way that we do our work. So it takes creativity for me as an academic to think about my work being done differently. A lot of people will refuse to think about their work being done in different ways. But actually, we can do our work in different ways. We just need to step outside of the sorts of things that we've been trained to do and have conversations with people with disability to, one, understand the enormous gifts and differences and creativity that they bring to our work, and two, the needs that they have that we can meet in order for them to really show that creativity. And one of the ways of doing it is through the sort of digital innovations that you do so well in Korea. You're so good at digital and innovations that can help people with disabilities. When I visited last year, there were so many learnings that I took back to Australia because you do that really, really well. So I think trying to have conversations with people with disability, understand the innovations that you have, and then that's one of the other keys to inclusion.
So I hope that your question was answered. But then this is not a simple question, so we need to continue to ponder upon this. But we're running out of time. I'm sure you're hungry. It's past noon in Korea, so it's time for lunch. And I'm sure you have a lot of other questions, but I hope we will continue to communicate on this topic later in the future. But with that, we would like to conclude the session. I'd like to thank all of you, the panel members and the audience, for their participation. Thank you.
Very much for the insightful discussions on how we can support people with disabilities as a community. I could definitely empathize on the vision of going beyond non-discriminating and integrating these people into our everyday lives. I think this session leaves a bold message to the society. Thank you very much. So our next session will continue at 1 p.m. Korea time. That would be approximately 50 minutes from now. And I hope to see you in the next session where we'll talk about the burden of disease in Africa. Thank you very much.